Pectus excavatum is when the chest wall does not develop as it should. The breastbone is also called the sternum and is in the center of the chest. With a pectus excavatum, the chest is caved in. It is also called sunken chest or funnel chest. We often just call it pectus for short. It is caused by an abnormal growth of the cartilage in the chest that pulls the chest wall and breastbone towards the backbone. Many kids don't have pain from it and are quite active in sports. Others may have chest pain, get short of breath, or have trouble keeping up with their friends in activities or sports. Most are embarrassed by the way their chest looks. We see it in very young kids, and then as kids are growing, it typically becomes worse. It becomes more noticeable during the teen years when kids are growing more quickly. More boys have it than girls, and it tends to be more severe in boys. It is an inherited condition, so in over a third of the kids we see, a family member has also had a pectus. Pediatric surgeons see this quite commonly, as about 1 out of 1,000 children have a pectus. Let's take a look at this skeleton to see how the rib cage is set up. You have 12 ribs on each side. The ribs on each side start from the back and join with the sternum in the front. The first rib is way up at the collarbone level. It is a little bit shorter, and as you get down to the lower ribs, they get a lot longer. When the ribs get about halfway around the front, right around the nipple line, the ribs turn into cartilage. The ribs in the back are bony, but as they come around the front, they are more flexible because of the cartilage. The cartilage joins with the sternum in the middle, which is pretty firm and less flexible. The reason the cartilage in front of the chest wall is flexible is that it allows our chest wall to move easily when we breathe. This is especially important when we are active with exercise and our breathing becomes deeper. The pectus is caused by abnormal growth of cartilages that are attached to the sternum. The cartilage is actually pulling the sternum towards the backbone. It often causes posture problems because it pulls your shoulders forward and makes you have this kind of hunched over posture. Sometimes exercises will help you strengthen your chest muscles, which will help your posture and may help the appearance of your chest. Exercises to help you have better posture and strengthen your chest muscles can help the appearance of your chest. Let's talk about how a pectus can affect your heart and lungs. There are 2 important things that your chest wall does for you. One is that it protects the heart and lungs that are right underneath the chest wall. The second function of the chest wall is a little more complicated. It allows the heart and lungs to function normally. That's where the flexibility of the chest wall becomes more important. When we are just sitting still, our heart fills with blood and gets bigger. When it pumps the blood out, it gets smaller. The same is true with the lungs. With normal breathing, as we take a breath in, the lungs get a little bigger. As we breathe out, they get a little smaller. When we start exercising, everything has to go faster. The heart needs to pump blood faster, so it has to fill more. It gets bigger the more it has to pump. As your heart gets bigger, it needs more room in the chest. The same is true for the lungs during exercise. We breathe faster and harder and expand the lungs more, which means more room is needed inside the chest. Kids with pectus have rigid chest walls, which makes it harder for the chest to expand. That's why we often do some testing of the heart and lung function while you are exercising. A pectus excavatum will become more noticeable until you stop growing taller. We check your pectus once a year to see how it is changing until you are about 12 years old. When you are between 12 and 13, there is often a large growth spurt and there can be a dramatic change in your chest wall. That's when we begin to talk about the timing of the repair. We use a grading system to talk about the depth of the sunken chest. The grades are mild, moderate, and severe pectus. We base our plan on the depth of the pectus. A complete history and physical examination is done on the first visit and includes taking pictures of your pectus. If we are seeing you each year, we will retake pictures each visit. Most patients will need to have heart and lung testing done to see whether their condition is severe enough to have surgery. We order a special X-ray called a CT scan that creates a picture of your chest so we can measure your heart and lungs and the space in your chest. The measurement is called a Haller index. We use this number to help us decide about the need for surgery. It is just one piece of information that helps us decide about the need for surgery. We may also do some testing of the lungs to see if the pectus is affecting lung function. This is called a pulmonary function test, or a PFT for short. The lung function is tested by having you exercise and then checking how the exercise affects your breathing. We may also recommend an evaluation of your heart, including an echocardiogram, which is an ultrasound of the heart. An examination by a pediatric cardiologist is done to look for any heart problems. All of the test information and examinations will help us decide the best procedure and the timing of the surgery.
The insurance piece is a big piece that as a parent you need to focus on when preparing for surgery. And the important thing to understand is that in order to get the surgery approved as medically necessary, versus like a cosmetic procedure for looks only, you need to know what kinds of tests are required by your insurance company, and it's very detailed. Sort of in their policy and procedures section, they'll tell you exactly what they need in order to look at everything ahead of time and pre-certify for the surgery. That's a whole process called pre-certification. And the administrative assistant in the surgeon's office was so helpful with this, and she really helped me to sort of know what to ask, how to get everything scheduled, and for us, and for most kids, it's that they'll need all those clinic notes from the surgeon. There is a test called a CT scan, and then also pulmonary function tests needed to be done. And then some insurance companies require also an echocardiogram, which is an ultrasound of the heart, and that requires a cardiology visit along with that. So it's important to get started with this part early, and just be sure that you write everything down, you get the name of who you're talking with, and then call the administrative assistant right away if you have questions or concerns.
There are two different surgeries that are done for Pectus Excavatum: the Nuss procedure and the Ravitch procedure. The Nuss procedure involves putting a metal bar under the sternum to push it out and keep it there. The bar stays in place for 2 to 3 years. It keeps the sternum in the correct position while you grow. The bar needs to be removed during another surgery in 2 to 3 years. The surgery to remove the bar is able to be done as a day surgery procedure. Your surgeon will decide when it is time to remove the bar. Both operations are done under general anesthesia. Here is what the bar looks like. It is made of metal and is very strong. It is placed through 2 cuts or incisions in the outer part of the chest wall, right here and right here. We use a scope during surgery so we know it is placed in the correct position. The procedure takes about 3 to 4 hours. This is a big procedure and there will be some pain. The pain team will help you manage your pain. We will share more information about the pain team and how we will help you with pain after surgery in a later section of the video. You will usually need to stay in the hospital for 5 to 6 days. There will need to be activity limits for the first 3 to 6 months after surgery. The bar needs to heal in place during that time. Your surgeon will let you know when you can start activities and sports again. As with any surgery, there are risks. They include the risk of general anesthesia, bleeding, and infection. There are also risks of injury to the organs and areas near the surgery. Risks of a pneumothorax, which is a collapsed lung or pneumonia, bleeding in the lung area, or a collection of fluid outside the lungs are all possible. The bar itself could move, or there may be irritation in the tissues around the bar. Your surgeon will go over all of the risks again before surgery. There are two different surgeries that are done for Pectus Excavatum: the Nuss procedure and the Ravitch procedure. The Ravitch procedure removes the abnormal cartilage growth that has occurred in your chest. Removing the cartilage allows the sternum to have a more normal appearance. Occasionally, we may use a steel bar behind the sternum for support. This bar would be removed in about 6 months. As your chest grows, cartilage grows back in a normal way. This operation is highly successful. Both operations are done under general anesthesia. It usually takes about 3 to 4 hours. This is a big procedure and there will be some pain. The pain team will help you manage your pain. We will share more information about the pain team and how we will help you with pain after surgery in a later section of the video. You will usually need to stay in the hospital for 5 to 6 days. There will need to be activity limits for the first 3 to 6 months after surgery. Everything needs to heal in place during that time. Your surgeon will let you know when you can start activities and sports again. As with any surgery, there are risks. They include the risk of general anesthesia, bleeding, and infection. There are also risks of injury to the organs and areas near the surgery. Risks of a pneumothorax, which is a collapsed lung and pneumonia, bleeding in the lung area, or a collection of fluid outside the lungs are also possible. Your surgeon will go over all the risks again before surgery.
Most kids and their family worry about the pain that comes with having surgery. We want you to know that we have a pain service to help you with your comfort and pain management after surgery and during your hospital stay. We will also help you with a plan when you're ready to go home. Someone from our team will be seeing you each day while you're in the hospital, and our team is available 24 hours a day, 7 days a week. If you're not able to get comfortable, we want to know so we can help. You'll hear me say often and usually because pain management is very specific to each patient. It is not a one-size-fits-all type of management. We adjust our plans based on your needs to keep you as comfortable as possible. Notice that I didn't say pain-free. You will have some pain. This is a big surgery, and it's impossible to safely take away all of your pain, but we will do everything we can to keep you as comfortable as possible. Okay, well, one of the most important things is for you to be able to tell us how much pain you're having. And as we talked about before, this is a big surgery, so we can do everything we can to keep you comfortable, but we may not be able to take away all your pain, so you need to know that up front. And what's really important is that from the time you wake up in the recovery room, people are going to start asking you what your pain is. So we have a few different pain scales that we use here, and for somebody your age, we would probably use the 0 to 10 scale. So 0 means that you have no pain at all. 10 is the worst pain in the whole wide world. And I always joke around with the younger kids and tell them it can't be any more than 10 because I only have 10 fingers, so you can't go any higher than that. So think about that as you're telling people their numbers. So usually when somebody tells us that they're an 8 to a 10 out of 10, that's pretty severe pain, and we think we need to do something to help them be more comfortable. So we may want to adjust your epidural if you have an epidural. We may want to give you more pain medication through your IV if that's how you're getting your pain medicine. We may want to add in other pain medicines. But usually when people are an 8 to a 10 out of 10, they can't do anything. They can't take deep breaths. They can't get comfortable in bed. Usually if it's like a 5 to a 7, it's kind of moderate pain. It's getting in the way of you being comfortable, but it's not obviously as bad as an 8 to a 10. And then usually the 1s to the 3s to the 4 is kind of minimal pain, and people are usually okay with that. Okay?
Okay.
So if people ask you from 0 to 10, right now, even before surgery, 0 to 10, with 0 being no pain, 10 being the worst pain in the whole wide world, how much pain are you having right now?
0.
Perfect. And then we're going to do our best to get you as close to that as we can. But again, there's probably going to be some pain. Okay? The anesthesiologist, who is the doctor who will help you go to sleep, will talk with you about options to manage your pain before the surgery begins. Most of the time, we are able to use an epidural. An epidural is a small plastic catheter or tube that is inserted into your back during surgery. The epidural is put into the epidural space, which is outside the spinal canal. It does not go into the area that has the spinal cord. The epidural medicines work in 2 different ways. One medicine, called Ropivicaine or Bupivicaine, is like the medicine you may have had from your dentist. It numbs the chest area. The other, morphine type medicine, stops the brain from feeling pain. Together, they will help take away most of the pain you feel. All medicines can have side effects, so we will ask you if you are itching, have an upset stomach, numbness or tingling, or if you're too sleepy. And I'm here to see how you're doing.
All right.
Yeah, are you comfortable?
Yeah, I'm good right now. I feel a little bit of pain.
Okay, what's your pain number from 0 to 10? If 0 is no pain and 10 is the worst pain in the whole wide world.
Probably 7.
Okay, is 7 okay with you, or is that too much pain?
It's a little much.
Okay, what number is okay with you? If 7's not okay, what number is okay?
Probably 5.
Okay, if you push your button, can you get down to a 5 sometimes?
Yeah.
Okay, it takes about a half hour to work though, doesn't it?
Yeah.
Yeah, that's just part of the epidural. That's normal. If you push your button a few times, does it work better than if you just push it once or twice?
Yeah, it seems to.
Okay. All right, I think what I'll do is talk to the doctors, and we might want to turn up the rate on your epidural so that you're getting more medicine all the time, because that'll help you be more comfortable, hopefully down to a 5 more often, and then you might not have to use your button as often. Are you having any trouble with itching or an upset stomach or anything like that?
No.
Okay. Can you wiggle your fingers okay? And your arms move okay? Okay.
Yeah.
Are you numb or tingly anywhere?
No.
Okay. How about your toes? Do your toes and your legs work okay?
Yeah.
Okay. Is there anything else we can do to make you more comfortable?
No, not that I know of.
Okay. One of the other things I'm going to do is talk to the surgery team about maybe adding in another medicine called Ketorolac, which is like giving you IV ibuprofen. So it would go through your IV, and the nurses would give it every 6 hours, and that helps a lot with this type of pain. So I'll see if we can add that in too. A few patients aren't able to have an epidural for certain medical reasons, and your anesthesiologist will talk with you before surgery about using a patient-controlled analgesia pump. That's short for PCA pump. With a PCA, a morphine-type medicine is given through your IV. The pump gives you some pain medicine all the time, even when you're asleep. You can also give yourself extra medicine by pushing a little button. The pump doesn't allow you to give yourself too much medicine because the pump is set up with a lockout time of 6 to 8 minutes. That's the number of minutes that must go by before the pump will give you another dose, no matter how many times you push the button. The PCA will help to take away most of your pain.
Is there anything that I can do to kind of limit the amount of pain that I have?
Oh, I'm glad you asked that. Actually, there is. One of the things that we've learned from doing this surgery, we've been doing it for a lot of years here, and one of the things that we've learned really makes a difference is that the kids who worry about things and the kids who get stressed about things and are anxious, they have a much harder time with their pain than the kids who kind of go with the flow. Are you somebody who worries about things a little bit?
Yeah, a little bit, but
Okay.
usually I can keep myself calm.
Good. What do you do to keep yourself calm?
I just think of good things.
Good, okay. One of the things that some kids come in already learning is relaxation techniques, like deep breathing techniques, or guided imagery is another technique that some people use, where you think about a good experience and you kind of take yourself back to that place and think about the smells and the sounds and the things that you're seeing, and that helps to relax people. But if there's anything like that that you already know how to do that works for you, we want you to practice those things while you're in the hospital. The other thing that helps is sometimes people will bring in an iPod, or if you've got a Game Boy that you like to play, anything like that that'll help you to distract yourself and relax. That'll help your pain. Sometimes I think that's more powerful than even some of the pain medicines that we use.
Now, how long does the surgery usually take?
The surgery usually takes a few hours from the time you get into the holding area, which is where the anesthesiologist will come and talk to you and your surgeon will come and talk to you, and then they take you back to the operating room and actually do the surgery, and then you go into the recovery room, which is where you wake up. And we have something that we started a couple years ago where your mom or your dad are welcome to come to the recovery room. Once you've started to wake up, they can come and be with you so that they can see you as soon as they can. So the whole thing usually takes a number of hours, anywhere from, I would say, 3 to 5 hours. And then after you're in recovery room, then you get to go up to your room, and that's where you'll spend the majority of your time.
And how long would you say I'd be hospitalized for?
Anywhere from 5 to 7 days. And it's really up to your surgery team, the surgeon who does your surgery, but usually it's about 5 to 7 days. And if they do the epidural for your pain management, we usually keep that in place anywhere from 4 to 5 to 6 days. And then it's usually a day or two after that comes out that you can go home.
Cool.
You're going to get through it, okay? Everybody does. It's a tough journey that you're starting, but everybody gets through it, and we're going to help you.
After surgery, the physical therapist and occupational therapist, as well as your nurses, work as a team to get you up and moving and doing your deep breathing exercises. What you'll find is you'll do a little bit more, and they'll set just a little bit more of a goal for you to take something else on, get up, go into the bathroom, and the sooner you get moving, the faster you'll get better. The day of surgery is pretty much a day where you're going to sleep a lot because of the anesthesia, and they need you to lie flat for 6 hours after surgery. There should be no rolling in bed, twisting, or side bending at the waist. That's important for the first 6 weeks after surgery. There really won't be any eating or drinking until the next morning, and that is not too much of a problem because you'll find sleeping is most of that rest of that day after surgery. First day after surgery, they'll begin to help you drink fluids and get some food going. They'll also be in a lot, the nurses and the therapists and the pain team, encouraging you to do breathing exercises because it's important to get moving a bit.
What we want you to do is at least 10 times every hour is to breathe in as deeply as you can, and that'll raise the little blue part in here, and you're trying to get up.
Not only does moving help with your lungs, but it helps to limit some of the stiffness that you feel from laying in bed a lot.
Is it feeling okay?
Yeah.
Okay.
And the first day, actually, your head of the bed can go up a little bit more, and it's really as far as you can feel comfortable with that.
Your mom and I are gonna help you behind your back like this, and then we're gonna have you take a big breath and blow out.
And then they'll also encourage you to sit on the side of the bed with some help.
And then while you're sitting up here, we're gonna have Michelle from the pain service come and look at your back and make sure that that's okay, okay?
Towards the end of the day, they'll be getting you up a bit more, out of bed, and actually help you to learn how to do your washing up and brushing your teeth. What they often did was encouraged Will to use his own remote for watching TV and holding his own cup rather than us jumping in to help him all the time. Second day after surgery, the therapist will work with you sitting up more at the edge of the bed and then taking steps and sitting in the chair.
And just take a deep breath there. Feel it? Okay, and then remember, bend
Usually
at your
they
waist.
want you to get up and sit in the chair 2 to 3 times for at least about 30 minutes at a time.
Do do remember that we don't want you doing any of that twist and turn in movements, so just being really careful.
So the goal today is really to help you get up and moving and to kind of work with you to be safe while you're doing
Getting
that.
your pants on and socks on is
Arm exercises are done 3 times a day, making sure that you don't do too much and pushing your pain level too high. And the therapists and nurses all work together along with the pain team to check your epidural and make sure that everything's going along as it should.
All right, well, I'll see you tomorrow, and then hopefully more of your lines will be all done and you can get yourself dressed.
The 3rd day after surgery is all about practicing getting up and sitting at the side of the bed and then standing and then really to walk in the hall.
Are you having any
They told us, 10 to 25 feet to make sure that walking
what I want you to do, I'm just going to kind of
starting to be more frequent.
and we're just going to walk out into the hallway, and we'll see if we can make it a little ways down the hall, okay?
Okay.
All right.
The 4th, 5th, and 6th day after surgery are very focused on getting you ready to go home. So they begin to talk about getting the epidural out or the patient-controlled analgesia, the PCA pump, down to a point where they can begin to give medicine for pain by mouth.
A little bit numb, like when you go to the dentist. Have you ever had the dentist numb your teeth? Okay, and you know how
The neat thing about that is that once that epidural comes out and the pain is less, they can take the Foley out and you can get up and take a full shower.
But other than that, keep doing everything for yourself when you get home, just like you weren't even at the hospital, okay?
Okay.
Any other questions?
And they really want you to be much more mobile. In fact, walking a full lap on the floor before you go home to the hospital is important. Being able to bathe and brush your own teeth and pretty much do all those things on your own is really a goal that they want you to have before you leave the hospital.
Around the nurse's station, and then let's try some stairs. Since you have stairs at home and at school, I want to make sure you can do a few of those. Sound good?
Yeah.
All right, so I'll just kind of follow you and we'll kind of check your balance. And if you need my hand, I'll give it to you. Otherwise, we'll just kind of head out the door.
I think one of the most helpful things to know is how to calm yourself down. And then also what you can do with your family members in terms of how much they can help you and to kind of help decrease that anxiety, get the kids taken care of, and those kinds of things. Because it is upsetting to see your child in pain, and it's anxiety producing when they go through surgery, and they will pick up on your anxiety, and that's natural.
In the beginning, the pain was hard to deal with, but you just have to realize that you have things like the pain button and that nurses and therapists are there to help you throughout your recovery.
And you really just need to be there for your child. And I took the time off I needed to from work, and I asked other people for help with rides for kids and meals.
My parents really were there for me. At first I wasn't used to having them ask all of these questions.
One of the things the doctors and nurses and the therapists kind of warned us about, which was great, was that we would really need to kind of check back in with Will about things that he was used to being very independent about, like going to the bathroom and about how his pain was, and to do the deep breathing.
They were doing what the nurses and doctors asked them to do.
They warned us together, Will and my husband and I, in the same room, saying, this is something we expect, and it might be hard for you guys, but you're going to need to realize, Will, that your parents are going to have to ask you more specific questions, and it's just a fact of needing to be more open about some of those private things that teens like to be in control of. So that really helped that they warned us about that ahead of time.
They would do things like help me when I went to the bathroom and I just had to get more comfortable with being open. It was a bit annoying at first, but I realized that it was something that I had to do.
So be confident and share your concerns, ask your questions, write down questions so that you can ask those of the staff you need to, and just do everything you can to kind of know how to calm yourself down and keep your anxiety in check.
After I left the hospital, one thing I realized was that I would have to do more quiet activities. I really wanted to get up and do more athletics and physical activities, but I realized that I wasn't able to.
Everyone at Children's was really helpful about knowing what to expect, and they did a great job of keeping us in the know of Will's progress and where we were going with each day, and that really, really helps to keep the anxiety lower, and just knowing that you're getting through each day and what to expect.
One thing that I found out was that I was used to having my cats sleep on my chest when I would go to sleep because it's their favorite spot to sleep. But I was unable to do that because it was too much pain for me, and I just have to realize that it's not the right thing that will help me recover. So I just have to realize that I just have to stay quiet for a while and slowly recover and don't get right into it right away.
I think just that open communication is really important with everyone.
It's also important that you get up and get moving so you can start your way onto a fast recovery, and you'll just be able to recover day by day, and it'll get better for sure.
Most parents and kids want to know when they'll be ready to go home.
At home, it is important for you to continue taking your pain medicines. We will give you prescriptions and go over the instructions for how to use them at home. If you are taking a long-acting medicine, it is important that you don't suddenly stop that type of medicine, so we will give you a plan to decrease it once you're home. You will have our phone number so you can call with questions 24 hours a day, 7 days a week. Our nurse will also call you at least once a week until you're done taking the long-acting pain medicine. It usually takes about 2 weeks, but again, everyone is different, so it depends upon how you're doing at home. If you don't need the long-acting pain medicine, the surgery team will provide prescriptions and teaching for the short-acting medicine. Either way, if ibuprofen was used in the hospital, it should be continued at home. One of the most common side effects of the pain medicines is constipation. We will try to prevent it by starting Miralax before your surgery and giving you Miralax and/or Senokot while you're in the hospital. It is important to continue those medicines at home until you are finished taking the prescription pain medicines and your bowels are back to normal. You will want to drink lots of fluids like water or fruit juice. Eating lots of healthy foods like fruits, vegetables, high-fiber bread, and cereals is also important.
There's some other things that you'll want to know before going home, and that is that you'll have a visit in the surgery clinic, usually in about 2 to 3 weeks. Then they reminded us to call, especially for any kind of fever, cough that doesn't go away, or trouble breathing, or if with deep breaths there was any pain. We also talked about any redness, drainage, or pus at the incision area, and any constipation or not stooling for a couple of days. And then, especially if Will were to get hit in the chest or have any kind of trauma at all to the chest, they wanted us to call about that. The staff, they were really great about making us feel comfortable to call with our concerns and questions, and that goes a really long way when you're going home.
Everybody does. It's a tough journey that you're starting, but everybody gets through it, and we're going to help you.
Thank you.